Welcome, everyone. We're going to get going in about 1 minute. We're still going to let some more people enter the Zoom space. All right, well, welcome everyone to the National Virtual Leukemia Conference. This is a one-of-a-kind conference addressing the unique needs of the blood cancer community and offers the latest information, tools, and resources to help support Canadians affected by leukemia. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation titled Chronic Lymphocytic Leukemia, What It Is, When to Treat, and What's Ahead. In this session, Dr. Sue Robinson, a hematologist at the QEII Health Centre in Halifax, Nova Scotia, will discuss how CLL is diagnosed, who will require treatment, why active surveillance is often the first step, and current and upcoming treatments. To begin, let me introduce myself. My name is Charlotte Hall-Coates, and I'm the Community Services Lead for the Atlantic region with the Leukemia and Lymphoma Society of Canada. I will be the moderator of today's event. Since there are many of you, we invite you to type in your questions and comments into the Q&A box on your Zoom panel throughout the presentation. An LLSC staff member will monitor the questions. I will read some of your questions out loud at the end of the presentation during the question and answer period. Due to the large number of participants and our limited time, we may not be able to answer all your questions. Also note that our speaker cannot answer specific questions about a person's health status. If we do not get to your question during the live presentation, a community services lead will reach out to you after the webcast. Today's presentation will be recorded, therefore you can come back and listen to it again on our website. Next slide, please, Dr. Robinson. If you have questions or cannot find what you're looking for, you can talk to the community services lead in your area and receive personalized assistance in finding answers to your questions or ways to address your concerns. We are here to help. Reach out to us by calling toll-free 1-833-222-4884. Next slide, please. We invite you to visit our new website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. On our website, you will find all our past webcast recordings, our podcast channel, information, fact sheets, practical tools to help you navigate your cancer experience, and much, much more. Visit bloodcancers.ca. Next slide. The CLL Facebook information and support group is an online community for individuals affected by CLL. It is a place to connect with others, share experiences, and encourage others also affected by this disease. Visit our website to learn more and join the conversation today. Next slide, please. It is now time to introduce today's speaker, Dr. Sue Robinson. Dr. Robinson is a hematologist at the QEII Health Centre in Halifax, Nova Scotia. She is a professor at Dalhousie University and teaches at the undergrad and postgraduate level. She has been the program director for the Hematology Residency Program and Hematology Unit Head for undergraduate medicine. She is involved in research, being the local principal investigator for studies in CLL, and has served on a number of national CLL advisory boards. She has a large hematology practice specializing in CLL. She was also secretary-treasurer for the Canadian Hematology Society and was a member of the Royal College Hematology Subspecialty Nucleus Subcommittee. Thank you so much, Dr. Robinson, for being with us here today.
Thanks so much for the invitation, and I'm really pleased to be here today. So here's my disclosures. I am on some ad boards, and I run some clinical trials locally. So here are objectives and how is chronic lymphocytic leukemia diagnosed, who will require treatment, why watch and wait is the first step, and what are the current treatments and what's ahead. So just a background of CLL, this is the most common leukemia in adults. The incidence is 5 in 100,000, up to 5 in 10,000 incidents in the 8th decade. The median age at diagnosis is 72 years of age. 40% of CLL patients are less than 60, and 12% are less than 50 years. And I do have a few patients that are in their 30s. So how is CLL diagnosed? So here's a little background of your anatomy. So your bone marrow is what I'll start with, and that is inside the bones in your body, and it's sort of a spongy material. It's like sort of a beehive, and in the spaces is where we make our blood. And then here's a vein and an artery, and the blood cells that are made in the bone marrow will then come out into the vessels and go through the circulation. So we all have these stem cells in our bone marrow, and they have the potential of making red blood cells, white blood cells, and platelets. Here, there's a number of white blood cells that are produced, and the most common one are neutrophils. Those are the most important for fighting infection. The next would be lymphocytes. And CLL is a cancer of the lymphocytes. So this is what a bone marrow would look like. On the left would be a healthy bone marrow. That red or pink ribbon is bone. And then there's lots of fat in the bone marrow. Those are those spaces. And then the little clumps of red and blue is where we make the blood. And to the right would be what a bone marrow looks like that has CLL. It's full of the lymphocytes giving that blue appearance. And here's healthy peripheral blood, and the red blood cells. The little clumps are platelets. Here are those neutrophils that fight infection, and here are our lymphocytes. Most of the lymphocytes in blood are T cells, but there are also B cells, and CLL is a cancer of the B lymphocytes. So here's what blood looks like for a patient with CLL. So there's lots of these CLL cells. This sort of pink amorphous substance is called a smear cell or a smudge cell. They'll often be commented on the blood report, and those are just decaying cells. So the diagnostic test for CLL, so first of all would be the blood test. You look at the CBC or the complete blood count, and there would be a high white count, and that would be because the lymphocyte count is increased. That could be reactive, but if it's persistent, and then the next test that needs to be done is called flow cytometry, and that looks for certain markers on the surface of the B cell, and if there is a certain marker, number of markers, and there is a certain number, they have to be at least 5 times 10 to the 9th per liter to qualify to be CLL. If those cells are there, but the number isn't there, they're less than 5, that would be called a condition monoclonal B cell lymphocytosis. And those patients have a 1% chance of developing CLL per year over time. SLL is a similar, it's the same disease, but these patients don't have the peripheral lymphocytosis. They have these cells that are found on a lymph node biopsy or biopsy of another tissue. Sometimes we do bone marrow tests on CLL patients, but we may not need to. We do them usually before treatment if there's a low hemoglobin or low platelet count. It is not required for the diagnosis. A CAT scan is often done prior to treatment to get a baseline of lymph nodes and spleen size. Here's what a cartoon of what the CLL B cell would look like, or the SLL B cell. And there's lots of these proteins that are on the surface. So in particular, CD20, CD19, CD5, CD23. If they find those markers, then that would be consistent with that CLL or SLL diagnosis. So just a word about staging. So we typically do staging for CLL stage. Rise stage 0 is just the high white count. 1 is lymph nodes enlarged. 2 is enlarged spleen and occasionally a large liver. 3 would be the red blood cells are low and it would be anemia. And 4 would be the platelets being low or thrombocytopenia. For SLL, the staging is similar to other lymphomas. And who will require treatment? So approximately 3/4 of patients will eventually need treatment, but a quarter will not. Most patients go through a period of watch and wait before they are needing treatment. And there have been studies to see if early treatment makes a difference, but it does not make a difference in survival. There is going to be a study in Canada looking at patients that are higher risk to see if earlier treatment might make a difference. But the standard of care now is that you would only treat when there's certain indications. So CLL is typically not curable. But the treatments are improving. It's amazing, the new treatments, and they are improving survival and giving longer remissions. And once treatment starts, the aim is to control the disease, minimize toxicities, and maintain a good quality of life. So here's, there are published indications to treat. So if there's progressive bone marrow failure, so the hemoglobin is dropping, the platelets are dropping, if the spleen is getting bigger and not stabilizing, but just progressing, that would be a reason to treat. If lymph nodes are getting bigger, if the lymphocytosis in the blood is doubling in less than 6 months, that's often not a reason by itself to treat, but it often is an indicator that it's getting time to treat. Disease-related symptoms are often weight loss of 10% or more. In the previous 6 months, fevers of 38 degrees for at least 2 weeks without evidence of infection, night sweats that are not occurring during the day, just the night, and getting progressively worse. Fatigue is a newer symptom that was added for a reason to treat. And if it's severe fatigue and there doesn't seem to be any other reason for it, sometimes, not often, that might be the reason to start treatment. CLL can have immune conditions, and one is an immune protein affects the red blood cells and or the platelets. And if this is the case, the treatment is steroids. And if it doesn't work, then it's probably time to treat the underlying CLL or SLL. There might be involvement of other tissues. Rather than bone marrow and blood, we might see skin involvement, kidney involvement, or lung involvement, for example. And if that's progressing, a reason to treat. So I've just put up some copies of just some CBCs from patients. So this is one, and the typical presentation of CLL would be someone who's asymptomatic, goes for routine blood work, and the white count's up a little bit. So here's a white count of 15. Upper limit of normal, and this lab is 13. And here's the breakdown of the cells. So what's making it high is the lymphocytes. They're 5.3. You remember, to have CLL, you have to have those CLL cells that are at least 5. So this is, the patient would have flow cytometry, and this would be the monocytosis, the monoclonal B cell lymphocytosis, not qualifying for CLL. But these patients would probably have their CBC done every 6 months, maybe every year, just to follow that lymphocyte count. Here's someone that I've been watching and waiting. White count is 68, upper limit in this lab is 11. Hemoglobin is starting to drop at 126, and platelets are starting to drop at 118, but the patient still feels great. No reason to treat. Physical exam is normal. On the differential, you'll see those smear cells that I talked about, 30%. Here's another patient that we've been following with watch and wait, and white count 268. Here are the hemoglobins now, 91. It's under 100. This would be a reason to start treatment. So we've had the discussion and then treatment was started. And here's another patient who didn't want treatment. White count is up to 430. Hemoglobin is down to 77, usually a level that we transfuse. He's decided that it is time to treat. And just a word about these high white counts, which can be very alarming to patients. It can be very alarming to physicians that don't see a lot of CLL patients. Because the CLL cells are very small, they typically don't cause slowing of the circulation. So the number of the white blood cell count is not an indication to treat. It's the other ones that I mentioned. Here's a totally normal CBC, and this is a patient that was treated and is in a complete remission. So watch and wait is the first step for most patients. And just a word about that. So typically you would just be doing a CBC every 1 to 6 months, seeing the patient occasionally to do a physical exam and seeing what their symptoms are. The white blood cell count and the lymphocyte count can plateau for a long time. It can fluctuate, or you can just see a very slow rise over time. The lymph nodes may start to enlarge. They can also be stable. They can fluctuate, and or they can steadily increase. CLL and SLL lymph nodes are very susceptible to getting larger if there's flu, a viral infection, fly bites, and so they might sort of quickly go up with inflammation and they come back to baseline. Symptoms may start to appear, and we talked about those symptoms. The usual duration of wait and watch is a few years, might be longer, less commonly, but sometimes it might be shorter. There's usually that gradual onset to treat. Usually nothing is happening acutely in CLL or SLL. For some, this is a very stressful time. They're aware that they are living with a cancer, but most are able to get back to their lives when they just start to experience that things are happening slowly and things might not progress. It's very important to have a healthy lifestyle. I mean, that's for everybody, but the risk of other cancers is increased in CLL. So it's very important to make sure that that risk is at a minimum. Don't smoke, exercise, have an ideal body weight, keep your alcohol intake up to the recommendations, keep vaccinations up to date. So current treatments, we'll move on to that and how to choose. And we're very fortunate that we have lots to choose from now, and that's just new in the last few years. So factors to consider when we're trying to choose a treatment, so patient considerations. When we just had chemotherapy with immunotherapy, the main thing we looked at was the age and fitness of a patient, and then we would pick the right one. We want to know their comorbidities to see how that might match with potential side effects of treatments, but also to see how we think they will tolerate the treatment. Very important to know patients' treatment goals, their preferences. How far do they live from a cancer center? I mean, some of the treatments do involve infusions, and what home supports do they have? There are disease considerations, and I'll go over that. There are treatment considerations. Some of our treatments you take continuously, some are a fixed duration, and then there are some unique toxicities that we will go over. So looking at the disease considerations, there are 3 tests that are important to do a risk assessment of CLL for that particular patient. IGHV mutational status, cytogenetics, next generation sequencing. So this is back to our cartoon of that CLL or SLL cell, and one of the membrane proteins that I didn't mention is the B cell receptor right here. And it's an immunoglobulin, and it's very susceptible to binding to antigens or proteins that circulate in the blood. And once there is that binding, it tends to activate a number of proteins inside the cell, and that promotes the cell to survive. Here's that immunoglobulin. In the green are the heavy chains, in the blue are light chains. Most of the molecule is pretty stable and doesn't undergo mutations, but at the very end, especially the heavy chain, there's a section called the variable region, and that's very susceptible to undergo mutations. About half of CLL patients will have a mutation there, and actually you'd think mutation is not good. A mutation is, in this case, is good in that it makes the CLL receptor less responsive to these antigens that it binds, and less likely to activate those proteins in the CLL cell. So the next thing, those next tests look at chromosomal and DNA mutations. So just a reminder, here's the cell. Inside the cell is the nucleus. And inside the nucleus are these chromosomes. And on the chromosomes are mapped the nucleic acids that determine our DNA. So that determines our eye color, our hair color. So cytogenetics is the study of chromosomes, and the most common test, if you read up on this, that we do for CLL, it's called FISH, fluorescence in situ hybridization. I don't expect you to remember that, but what we end up seeing is they display the chromosomes, and there are 22 of these chromosomes. Then there's the X chromosome for females, or XY chromosome for males. There's 2 of each. There's a lower part that's a longer arm, that's called a Q arm, and the upper arm, which is shorter, is called the P arm. In CLL, we can typically see normal cytogenetics, or we can see changes in 11 where there's a deletion in the Q. The lower arm, we can see mutations in 12, where typically it would be an additional chromosome, so trisomy 12. In 13, it would be a deletion of Q. And in 17, it's a deletion of the small arm, the P. So this is just showing frequency. So deletion 13Q would be the most common. That's considered good risk when it comes to response to treatment, especially the immunochemotherapies. And then deletion 17P would be the highest risk, and about 20% of patients will have normal cytogenetics. So just a word about the third test, which is next generation sequencing, and that's looking for mutations in a particular gene called TP53. So that gene lives on the small arm of the 17 chromosome. And most people that have a mutation in the TP53 also have a deletion in 17P on the other chromosome. So you're going to identify this problem by doing that FISH that we talked about. TP53 is a very important gene that helps protect us from cancer. If there are mutations, this is commonly associated with many cancers and also CLL, SLL. But about a third of patients, they don't have the deletion of 17P, but they do have that mutation of the TP53. And so you do have to do the additional test called next generation sequencing. And I'm happy to say that I think in Canada, most of these tests are getting done. If the local lab doesn't do it, there are a number of reference labs close by. So just the history of treatment of CLL, and in the 1950s, we had chemotherapy, chlorambucil, bendamustine, fludarabine, cyclophosphamide, and then a number of years until 2002, until we saw CD20 monoclonal antibodies. So CD20, you might remember, was one of the proteins on the surface of the cell, of the CLL cell. So these monoclonal antibodies target that area. Then we've gone a few years. In 2013, we had the first targeted therapy with ibrutinib. There's since been a number, but that's just 9 years ago. So a lot has happened in the last few years. Stem cell transplant may be offered to younger patients who have relapse disease. CAR T cell is still an experimental treatment, very promising for some lymphomas, and a lot of research is starting in CLL. I'm not aware of CAR T cell studies in Canada. I think they will be coming, and it's a very promising treatment. Radiation and splenectomy is uncommon treatment for this cancer. Chemoimmunotherapy, these are the ones that are available for first-line therapy in Canada. Early on, we learned that adding a monoclonal antibody to chemotherapy improves survival of patients. So FCR, fludarabine, cyclophosphamide, and rituximab was studied and published in 2010. This was for younger, up to age 70 fit patients. Median progression-free survival is 5 years. The progression-free survival is a term I'll use quite a bit for studies. So this is the average time that a person is in remission, and that's 5 years. And then once they have relapse, it might be another period of time before they need treatment. Bendamustine and rituximab is for older fit patients, 4 years for progression-free survival or remission on average. Chlorambucil and obinutuzumab was studied in older and or unfit patients, and median progression-free survival 2.5 years. So it soon became evident with the immunochemotherapy that doing this risk assessment of the disease in patients was important. So here's the long-term follow-up of one of the FCR studies, and you'll see the red line. So these are patients that have immunoglobulin heavy chain variable region, IgHV mutated status, and there's a cohort that are out 16, 20 years. They have not relapsed, and you go to some of the meetings and they do talk about whether this cohort may be cured. Then we have, here's the IgHV unmutated group, or people that have the deletion 11q mutation. They don't do as well, but here's the progression-free survival. So you go to 50% and you come over, and so it's just around 5 years would be the average remission time for these patients, but they don't do as well as the mutated group. So here's 17p or TP53, and here their median progression-free survival is about 2 years. So don't do as well. This is FCR or with other immunochemotherapies. So moving on to targeted therapies. So here, back to our cell. So this is a more complicated cartoon. So here's that immunoglobulin, the B cell receptor, and here's that area on the heavy chain that could be mutated or unmutated. And then what happens when it binds to the antigen? This receptor on the surface activates enzymes that are inside the cell, and then they will then promote the survival of the cell, growth and proliferation of the cell, and also binding of the cell to protective cells in the bone marrow or in lymph nodes. There have now developed treatments where these different enzymes are inhibited, and so then the cells will die more easily, which would be a good thing. So the treatments that we use for first line, there are some BTK, bruton tyrosine kinase inhibitors. There's PI3K inhibitors. We have one idelalisib for relapse disease in Canada, and then BCL2 antagonists or inhibitors, and that is venetoclax. So what we have in Canada for targeted treatments, the BTK inhibitors, so they have to be continuous treatments. They're oral. You would take them until your disease recurs or you don't tolerate. We have acalabrutinib, Calquence, ibrutinib, Imbruvica, zanubrutinib, Brukinza. And then just in the last year, we've had approved in Canada, I think most provinces now, venetoclax or Venclexa, which is given with obinutuzumab, with the advantage of only being on treatment for 1 year. So this is looking at ibrutinib, since that's the BTK inhibitor that's been on, and targeted therapy that's been on the market for the longest. So the yellow line is the progression-free survival of using it in first-line therapy, and the purple is using it in relapse refractory disease. So we're up to 7 years after using ibrutinib, and progression-free survival, the median progression-free survival has not been reached, and about 80% of patients are still in remission. At about 5 years or 67 months, half the patients, or 55%, are on treatment, but that means around half of the patients have stopped treatment by then. And the most common cause for stopping treatment is adverse events. Here's one of the studies with ibrutinib. It was comparing it to chlorambucil and obinutuzumab, and this is looking at those high-risk features, so unmutated IGHV, deletion 11q, deletion 11p, and or the TP53 mutation. So here's the ibrutinib treated group, and what you can see is the line is pretty flat. They're only out 3 years here, but it shows that ibrutinib is very effective in these high-risk patients. This is another study with ibrutinib comparing it to FCR. And what this shows on the left is the patients with IGHV unmutated status. The red is the ibrutinib, so they're doing better than the treated group with FCR. But when you look at the IGHV mutated group, they're doing equally well in terms of progression-free survival. So here's a patient of mine, 54-year-old female. Her risk status of her disease, she had 13q deletion. She also had 11q deletion. She had IGHV mutational status of being unmutated, and her next generation sequencing was TP53. So I hope that you would see that with some of these high-risk features, I would not want to give her chemoimmunotherapy, for instance, FCR. So looking at the adverse events, so with ibrutinib, it became clear with clinical trials that there was a risk of developing atrial fibrillation, which is an arrhythmia of the heart, which is common in older patients, but seem to put them at higher risk if they're on this drug. Some bleeding, most of the time minor, but can be more serious, hypertension, and infection. So then there was the development of more BTK inhibitors, but that we call second generation inhibitors. So it was felt that the side effects of the first generation ibrutinib was due to the drug affecting some enzymes in other organs. So then these second generation drugs were more targeted to the particular enzyme BTK in the CLL cells. They've been found to be equally effective with less side effects, and there have been head-to-head comparison studies with both acalabrutinib and zanubrutinib. So here's the acalabrutinib comparison study. It was called Elevate, our relapsed refractory disease. I love all the titles of these studies. So it was comparing acalabrutinib, which is 100 milligrams twice a day orally, to ibrutinib, which is 420 milligrams orally. And they were equally effective, but what they saw was difference in toxicities. So over here on the left are the cardiac events. So A stands for acalabrutinib, I is ibrutinib. So for all grades, cardiac events were 30% ibrutinib, 24 acalabrutinib, that arrhythmia, atrial fibrillation or flutter, 16% with ibrutinib, 9% with acalabrutinib, hypertension, 23% to 9%. Bleeding events, 51% to 38%, but for major bleeding events, they were the same, about 4 to 5%. Infections, about the same. And over on the right, looking at more common side effects, for acalabrutinib, headache is quite common. So in about a third of patients up front, they will get headaches. They tend to be mild and short-lived and respond to Tylenol and caffeine. But for some patients, 2%, they can be quite severe. And then cough is listed to be more common. With ibrutinib, more common is diarrhea, arthralgias, back pain, muscle spasms, and dyspepsia. And there have been studies that show that the side effects, most of them do get better over time. So for follow-up of almost 4 years, looking at reasons to discontinue treatment because of side effects, 15% in the acalabrutinib arm and 22% in the ibrutinib arm. So this was the Alpine study that was comparing zanubrutinib with ibrutinib. And just looking specifically at that atrial fibrillation and flutter. In this study, ibrutinib was 12% instead of the 16%, and zanubrutinib was lower, around 5%. This was a shorter follow-up, 2 years, but looking at reasons to discontinue for adverse events, 13% for stopping on the zanubrutinib arm, and 17.6% for stopping on the ibrutinib arm. So this slide is just showing we're moving on in research and coming up with even better BTK inhibitors. So the ibrutinib, acalabrutinib, and zanubrutinib, they all bind to that BTK enzyme at a certain spot. And over time, that spot can become mutated, and then the drugs don't work anymore, and the patient is resistant to those drugs because of that mutation. So they've developed some new BTK inhibitors. They're called non-covalent, and they bind at another spot on the enzyme, so they can overcome the resistance to these ones below. And there is at least one study, hopefully another one in Canada, looking at pirtobrutinib in patients that have previously been treated and become resistant to ibrutinib or one of the other BTK inhibitors. Moving on to the other class of targeted therapy, so venetoclax is the BCL2 inhibitor. And I mentioned that venetoclax and obinutuzumab just became available this year in most provinces. This was based on the results of the CLL 14 trial, which was a German study. And in Halifax, we were very fortunate to participate in this. And the advantage is you're only on treatment for 1 year. So the study design, it was designed for patients that had coexisting medical conditions. So this was typically the older patients that had a number of medical problems. And this is how it's been approved in Canada in most provinces. So looking at the latest follow-up, so over 5-year follow-up, 65 months, the blue arm here is the venetoclax obinutuzumab, I'll call it Ven-O, and that median progression-free survival, if you go over and find 50% and come over here, it's not been reached yet. And this was chlorambucil and obinutuzumab, and definitely Ven-O is superior. Looking at some of these high-risk groups, so here on the left, we have the TP53 positive patients, in the solid line. So blue is Ven-O and the red is the chlorambucil and obinutuzumab. You can see that Ven-O is superior. The dashed line is the patients without the mutation, and they do better. Over here on the right is the IGHV unmutated in the solid line. So Ven-O is superior to the chlorambucil and obinutuzumab. So one thing about venetoclax, when they first did this first studies for this drug, they found that it was very potent, worked very quickly, and caused very quick cell death of the CLL or SLL cells. And what can happen when cancer cells die in circulation? They release their contents. So there can be a number of electrolyte abnormalities. Those electrolytes all need to go out of the circulation, so they go out via the kidneys. It can cause a lot of stress and sometimes damage to the kidney. So that's called tumor lysis syndrome. So there were some patients early on with the very beginning studies of venetoclax. So they quickly introduced some measures to make sure that the tumor lysis syndrome risk was very, very low. So the main thing, or one of the main things they did, was ramping up the dosing. So instead of starting at full dose, you start at a small dose, and every week you go to a higher dose, and then at 5 weeks, you're up to the full dose of 400 milligrams. And the other thing they did is they came up with a table that would give you a risk of the patient developing tumor lysis syndrome with treatment. And it was a risk of that was low, medium, or high. It was based on the size of the lymph nodes. The bigger the lymph nodes, the more likely there would be tumor lysis. And the higher the lymphocyte count, the more likely there would be tumor lysis. So for low and medium, these patients are treated as outpatients. They do need blood work done before and 6 to 8 hours after the pill is swallowed. And then they need it done the next morning, 24 hours after they've taken the pill. And if all is good, then they don't need any more monitoring until the next week, and they go through the next blood taking with the next dose. If patients are living out of town, the doctor may want them to come into the cancer center and stay at a lodge or a hotel, and so that the blood work can be done promptly. And if the electrolytes are out of whack, they may need to bring them into clinic or to the emergency room to give them fluids or correct the electrolytes. For high risk, most of the patients are low and medium risk. For high risk, it is recommended these patients get hospitalized, usually for a day or two, and they get fluids and they get more blood monitoring. So what's ahead? I'll move on to that. Can there be an optimal treatment that is fixed duration? And I think right now we think that would be the best, that probably toxicity might be less if you're not on a drug long-term. So a flare, another great name for a study, is this was an abstract this year, and it's a study out of the UK, and they compared FCR, so that's for young fit patients, comparing it to ibrutinib alone, but also to a combination of venetoclax and ibrutinib. And interestingly, it's been tolerated very well, and the response rate has been very good. And some of these patients are able to be off treatment, and it looks like the majority at 2 years. Another trial that's just out in abstract form is another German trial, CLL 13. And this is looking again at young patients or older patients, but fit patients. So the one arm is FCR or BR, and they're comparing it to 3 venetoclax arms. So it's venetoclax with rituximab, venetoclax with obinutuzumab. So that would be what we have in Canada based on that CLL 14 trial that was studied in the older unfit patients. And the last arm is venetoclax, obinutuzumab, and ibrutinib. So the results are early. So this is just over 3 years. But looking at progression-free survival, it looks like the best ones are the black, which is the obinutuzumab, is the G, ibrutinib venetoclax, or the obinutuzumab with venetoclax. So they look to be the superior arms. And then we have looking at the results of, remember that group, mutated IGHV, and they're the young group. And you might remember that diagram I showed you of the FCR results, and this was the one that we had some patients in that cohort that were out many years without relapse. So this is, again, short follow-up. This is the chemoimmunotherapy. So this is FCR in the blue. So looks very promising for no relapses yet. And then the black is the obinutuzumab, ibrutinib, and venetoclax. And the red is the venetoclax, obinutuzumab. So this is looking very promising. We obviously need longer follow-up, but it's also showing that the obinutuzumab venetoclax is looking very good in young fit patients. So hopefully we'll be able to get that available in Canada for that population. So conclusions for first-line therapy in CLL or SLL. The BTK inhibitors, they're oral, they typically don't require clinic visits. They result in prolonged progression-free survival, including high-risk patients. They were certainly a real, it was wonderful to have these drugs, especially with COVID, and patients were able to stay at home as much as possible. The second generation BTK inhibitors, acalabrutinib, zanubrutinib, there's less toxicity, in particular the cardiac, the atrial fibrillation, and the hypertension. Venetoclax, obinutuzumab provides a fixed duration treatment with deep responses and prolonged remissions, but does require more upfront clinic visits. Chemotherapy is still an option, especially FCR for those young fit patients with good risk disease, including the IGHV mutated status, with the possibility of very prolonged remissions. So I think with that, I'm coming to the end, and I will just go over the objectives, and I'm hoping that you all got something out of this talk, because I know your knowledge of CLL is variable, but I know some of you know it very, very well. How is CLL diagnosed? Who will require treatment? Why we go through that watch and wait approach as the first step in most patients? And what are the current treatments and what's ahead? So thank you, and we'll take questions.
Perfect. Well, thank you so much, Dr. Robinson, for that very insightful presentation and for being with us here today. So it is now time for the question and answer period. If you haven't already done so, please make sure to get your questions into the Q&A box on your Zoom panel, where you can type out all your questions there. As we mentioned before, we have received a really, really large number of questions during and then also before the presentation. So we may not have time to get to all of them, but the community services in your area will follow up with you directly after the presentation. So let me get my questions set up here. All right, so to begin us off, someone asked, what is considered young patients for certain treatments? So what would you consider sort of a young patient when determining treatment?
Yeah, so age comes into it, I think, primarily with the chemoimmunotherapies. Young, most of the time was defined as less than or equal to 65, and in some studies, it was less than or equal to 70.
All right, perfect. And then someone asks, is FCR still considered the best treatment for someone who is, considered young? They gave sort of mid-50s as a baseline.
Yeah. So I think, in these days, we do have options and you have to have the discussion. So age is important, fitness is important, but I think those risk assessment tests of your CLL are very important. So if you're young and you've got unmutated disease, that was the IGHV unmutated status, then you won't do as well with FCR. If you've got the mutated status and everything else is good, you don't have any of the other sort of high risk deletions, you don't have that TP53, then FCR is certainly still an option. And I think you'd have to have that discussion about what does each protocol look like, what are the pros and cons, what are the potential toxicities. But still, I think it's on the table for good risk young patients.
Perfect. Thank you. And just a reminder to everyone, always important to consult with your own healthcare team, especially around questions around treatment and side effects. They're the ones that probably know best. So staying on the topic of age, do you see a correlation between age of diagnosis and those who stay sort of in that watch and wait phase longer? Does being younger mean a more prolonged watch and wait?
Yeah, not that I know of, not that I know of. There are some scoring systems that sort of predict how long it will be before you need treatment, and age is in there. So age would be a factor, that the older you are, the less likely you'd be in watch and wait. But I don't know of any good study that tells us about correlating age to how long a watch and wait is.
All right, perfect. Thank you so much. There were a couple questions that came in around testing, especially around IGVH mutation testing. If they cannot get it done at their local hospital, like, is there somewhere in Canada that they can get it done? Like, if it's not being referred?
Right. So most of the labs, most of the clinics in Canada, we would be doing the testing prior to starting treatment. I think there are a couple of international guidelines that would say you should do that testing before you start treatment. If you want the testing done prior to treatment, you just want to know, have that discussion with your doctor. But I do believe that this testing is available everywhere in Canada. And if the lab is not, if your local lab doesn't do it, there are a number of reference labs.
Perfect. Thank you. So we got quite
sorry, and I would just mention also, this is one of the tests that doesn't change. Like, once you get that mutational status, it never changes. The other two tests that I talked about, the FISH and the next generation sequencing, they can change. And there are some guidelines to say that maybe they should be retested prior to every treatment. And then there's ongoing arguments that with the new targeted treatments, maybe we don't need to retest. So, have that discussion with your doctor.
Perfect. Thank you so much. So we got quite a few questions come in around vaccines, specifically, COVID-19 vaccines, but also just more general vaccines, the seasonal flu, shingles. Should I, as a CLL patient, get a vaccine?
So definitely yes. Not a live vaccine. So we now, for shingles, we can get the dead virus or vaccine. There are studies, and especially with COVID, growing studies to say that the response to the vaccines may not be as good as someone that doesn't have CLL because of the some problems with the immune system. But if you have CLL and if you're on treatment for CLL, you may certainly get sicker with any of these viruses. So So I think definitely, and pneumococcal, you should be getting as much protection as you can.
Perfect. And then someone asked about vaccine reactions. Do you see an increase in having those sort of post-vaccine reactions in someone that has CLL? So whether it's, a fever after feeling unwell, that kind of thing, or is it the same as sort of the general population?
Yeah, I think it's the same as the general population. I'm not aware of anyone with CLL or any other cancer on treatment being more likely to have reactions.
All right, perfect. And then someone was asking regarding COVID infection. Do those with CLL have a poorer risk of outcome if they get infected with COVID-19? And does it matter if they're in remission, watch and wait, or treatment?
Yeah, that's a good question. And I think the treatment of someone that's got a COVID infection is probably slightly different in each province. I know in Nova Scotia, there is a treatment for COVID if you've got an active infection that Paxlovid that can hopefully reduce the likelihood of getting very sick. If the Department of Health is aware that you have the COVID infection and you meet certain criteria. So you would be on treatment for our province. You would be eligible to get the Paxlovid. So you would have to have either got a PCR testing so that they're aware of it, or if you did it at home test, you'd have to go online and register and say that you've got COVID to get this. If you just have CLL, they're not giving that for those patients. They have to be on a treatment. They have to, and other cancer treatments, those patients would qualify.
Right. Well, good to know. And just a reminder to everyone, check out what your province is saying when it comes to those preventative measures or post-COVID treatments. All right here. Switching gears a little bit, we had a couple of people ask about specifically SLL. Is SLL treated the same as CLL in terms of like treatment options?
Yes. Yeah. So most of the trials in recent years include SLL with CLL. In older days, SLL was more included in lymphoma trials, but nowadays SLL is treated as CLL. And probably around the whole spectrum of people that have CLL, SLL is probably somewhere like 7% of those patients have SLL as opposed to CLL.
Perfect. And then someone was asking, can SLL turn into CLL?
I was just about to say that. Yes. Yeah. So it's very interesting. We don't know what causes those CLL cells to stick to an environment, like what causes the SLL patients, their cells to stick in a lymph node and not circulate into the blood. But they can change over time, and you can have someone that's only had those cells in their, say their lymph nodes, maybe a little bit in their bone marrow, and then they start to something's changed, and those cells start to circulate. So yes, you can go from one to the other.
Perfect. And is there any precursor to why it might mutate from SLL to CLL? And is there sort of a timeline or?
No, I don't know of any studies that have looked at that. I'm just guessing from my experience. I can't think of a study about this, but I think most SLL stay as SLL, but certainly there is that proportion that will become a CLL over time.
Perfect. And then someone asked, is CLL ever considered cured, and they heard, and I know I've heard this quite a few times, that their hematologist will tell them, you'll live with it, but you probably won't die from CLL. So sort of what's considered cured, or is there a cure?
Yeah. Yeah. So, that's a tough one, because I think the bottom line, as we say today,